Hi, I'm Danny Van Leeuwen. I'm Health Hats. Thanks for joining me. Today, we're going to talk about CMS quality measures for people. So let's take that apart a little bit. So, CMS is the Center for Medicaid and Medicare Services. CMS manages a huge proportion of healthcare today. And CMS, as well as the rest of the healthcare payment industry, is shifting from paying for value rather than fee for service. So, fee for service is um, every, paying for every procedure, every test, um, or being paid for every service, every test. And paying for value is paying for the outcome of that service, theoretically, anyway. So, value, the key is what is value? And value is based on quality measures, measuring something about health. And then paying people for attaining it rather than for every single service. The challenge is that value is being paid for by the performance of individual physicians. So, not so much whether you and I attain optimal health or how the whole health team is functioning, but individual performance. So I was nominated to sit on a CMS technical technical expert panel about quality measurement development. So not so much about the quality measures themselves, but about how they're developed. This is a technical expert panel managed by a company called Battelle and under contract with CMS. So I was honored to be nominated and I accepted it because I feel like what we measure and how we measure so much is driven by this whole value-based thing. So my goal as a patient advocate is to find one lever that can move the value-based measurement battleship 3 degrees so it's a little more focused on patients, caregivers, parents, and our direct care clinical partners. So I'm one of 19 panel members, and I'm one of 2 who have expertise in all 4 of the selection criteria: consumer perspective, clinical content, performance measurement, coding, and informatics. So the good news is that the technical expert panel met recently in Baltimore, and the panel gelled as a team, and the leaders from CMS and Battelle seem open, if not eager, for actionable advice. So my superpower is to accept what is and go from there. So I came up with this list of 9 things that talks about, like, where are we? So what is? We have to understand the current situation. So the first one is, as I said before, is that measures are evaluating the performance of individual physicians, not measuring whether we attain optimal health or how the team is functioning. Second, inertia in the measurement world is increasingly getting more specific by specialty and diagnosis. So, specialty, cardiology, nephrology, neurology, surgery, or diagnosis, um, heart disease, diabetes, uh, um, fractures. Um, okay, not really. So it's getting more specific by specialty and diagnostic, but not really towards the non-medical um, determinants of health. And determinants of health, if you recall in our previous conversations, include a medical care, individual behavior, genetics and biology, um, the physical environment, etc. And it doesn't really recognize that we are not a sum of our diagnoses. There's more to we are more than the sum of our diagnoses. So third issue about what is data for measurements exists primarily in claims data, diagnostic meaning lab tests, radiology, and the electronic medical record. Much less patient generated data, and our experience and perceptions of people at the center of care: patients, caregivers, parents, clinicians, direct care, support staff. Fourth, the measurement science is more mature about medical outcomes than experience and perception outcomes. So it tends to focus in that arena. Fifth, practitioners really bristle at the idea of being held accountable for anything they deem out of their control. So there's pressure to think about that, as opposed to an attitude of, what can I do to contribute to whatever's being measured getting better? Sixth, clinicians, patients, caregivers, insurers, policymakers are all really ill at ease with uncertainty. They want things to be black and white. And as we know in life, they aren't. Life is uncertain, but it's really uncomfortable for people. Seventh, few, if any, incentives exist for data vendors to integrate their data. So what that means is that data is collected in very many different places. And if we're trying to think longitudinally, so longitudinally is across time, usually that data, it's very difficult to collect that kind of data. And it's data that happens across transitions in care, moving from one setting to another. And people who are the sickest are usually the people who are trying to or having to carry their data from one setting to another, if they're able to do that. 8, that testing measures in real life seems like an insurmountable challenge. And so what happens is that measures and data are tested in laboratory conditions, but our lives are not laboratories. And so the link between measures and what they're supposed to measure and the measurement and the value to patients seems tenuous to me. And finally, not of the least at all, is that direct care clinicians are stressed and burned out. And what we see that is that they're spending more time documenting and less time with us. And it would seem that it would be good if technology could reduce those trends rather than increase them. So, Houston, we have a problem. So, I smell two opportunities to shift this battleship and support people at the center of care. So bear with me. The first one is people gravitate towards what's being measured. And if our measurement is getting more and more specific by diagnosis, and it's about performance of individuals, it leaves out the team. And what is something that is being done by the team that's important to everybody? And I think it's about making choices in our healthcare. So this is called clinical decision support. Informed decision making using clinical decision support by our lay and professional health team is a new area of clinical quality measurement. Yet it has a growing body of associated evidence about clinical decision support. So it has that combination of some evidence behind it, plus being a relatively new area of measurement. It combines medical and non-medical determinants of health. It could make use of patient-generated data that could then be integrated into electronic health records and personal health records. It bridges home, community, and healthcare facilities. It includes medical outcomes, workflow of clinicians, life flow of us, and perceptions of all the people at the center. It could shift some burden from the direct care clinicians because we as patients would be doing more of the data collection, and it would empower us as patients, parents, and caregivers. So the first one, consider measuring clinical decision support. The second area is to build an infrastructure for testing measures in real life. Until there's an infrastructure that supports a shift towards the use of patient-generated data, including perceptions and experience of people at the center, and that integrates the continuum of care, measurement will always do what measurement has always done. And there's no evidence without testing. So if we're going to test, if it's going to be about real life, we have to test in real life. So I meant what I said when I said I smelled an opportunity. Clearly, these bones need meat. So my question for you is, am I onto something? I'd like to go to the next technical expert panel at the end of January, the beginning of February, with a more mature proposal. My feeling is that groups react better than create. So give them something to react to rather than ask them to create something. So I need your help to create. So please comment on this video. There's a space at the, below the video on YouTube, and comment. And thanks. Have a good one.